occurred to me so far is that this journey has been basically a series of one decision after another in terms of, what's the best thing to do and when, and how to kind of proceed with any situation that occurs. And having chatted kind of to a few different people around, around this condition, other rare diseases as well, we feel like it's kind of, how to make a difficult decision, and often feeling like ideally someone else could make it for us. We're looking, to you guys, the experts, often, to help us with that. So something that I remember you saying was, with this condition particularly, but actually really any, healthcare, that everything needs to be discussed on a very, very personal basis. So, obviously there are protocols and things in place, but behind the graphs and everything, the stats and things, there's ultimately a human being with a life and everything else that's going on. And I wondered what are some of the factors that you look at that very much determine the route that you might take with a patient, whether someone's considering that kind of watch and wait situation, or do we intervene, medicine, surgery, what is it?
Okay, well, two things. First of all, as you know, we're all into MDTs in a big way, but they're slightly misinterpreted. The MDT is not a decision-making process. The MDT allows a lot of expertise to be brought together at the same time. So a pathologist, particularly, we really know what we're dealing with, a surgeon to see what the options are, a radiologist to tell us whether things are really abnormal or not abnormal, etc. At that meeting, we can then throw out, this is a situation, what do we feel are going to be the options? But then the one person who's not there, of course, is the patient. So what we do at that stage is, first of all, that there has to be a nominated consultant, the person who knows the patient. It's not sort of thrown into the ether. Sometimes it may be a nurse, which is fine. But then you go back to the patient and explain, these are the options, these are what we've considered, these are the risks for the different procedures. And you're empowered to say, that sounds great, you'll think this is a really good idea. These side effects, the surgical risks, do sound pretty horrendous. I'd rather undergo surveillance. So it's a very sort of collegiate process where we get the best expertise, and that's why people like yourself really should always be discussed in a major centre, even if your day-to-day care is somewhere more peripheral. And that information is then brought together to say, well, how do you feel about this? Now, clearly, a girl of 25 who's got a small lesion, it might not be appropriate to consider a total pancreatectomy with all that involves. And equally, somebody of 85 who's got an enlarging lesion, we may not be too proactive. If, on the other hand, you've got a lesion in the pancreas that's really looking a bit dodgy, and we think surgery is relatively safe, that might be one where it would push somebody, unless they're very averse to surgery, to say, yeah, I think maybe that's worth going forward. So it ends up as a joint process. And as I always say to patients when they look sort of askance, saying, I don't want to do that. Well, it's your body. No one's going to make you either take drugs. There's no point prescribing drugs if we know patients aren't going to take them. And there's no point organizing an operation. The patient's not going to turn up. So it has to be an agreed process. Now, it may not always be totally satisfactory. And the problem is that sometimes there are no right answers, as I'm sure you know. And equally, what can be problematic is when somebody seeks a second or third opinion, because you get 3 doctors, you get 4 opinions. That's difficult, and it ends up as a question of judgment. My personal feeling at this stage is I would, if it was me or mine, opt for this, but you mustn't decide that. So I think it's that in many cases there are right answers, there are agreed guidelines, and I always say guidelines are not protocols. These are a guide, and you don't have to obey a guideline, but if you don't, then you have to sort of explain, at least to yourself, why I'm not following the guideline. So, you've got hyperparathyroidism, your calcium's very high. The standard treatment, most of us agreed, is 3.5 gland parathyroidectomy, take out the thymus, then watch the calcium. And that will probably give you a normal calcium for 10 years or possibly longer. Some people might go for total parathyroidectomy, tend not to, but that sort of decision is fairly straightforward. You've got a small pituitary tumor. Most people know exactly what to do with those in terms of the pituitary tumor world. The more difficult ones are bronchial carcinoids, the pancreatic tumors, which is always a little bit iffy, because you say, well, is it safe to leave a small tumor that's 1.5 centimeters? And I can show you the statistics, and you say, well, if it's less than 1 centimeter, there's a 3 to 5% chance of it becoming malignant. If it's 1.5 centimeters, it may be a 10%. Nothing is free of risk, and then you just make a considered choice. And a young person may say, if you're going to watch me carefully, I'm happy to observe it. An older patient may say, well, I've got this far. If you can remove that tumor safely, that'll make me and my family feel more comfortable. So, do you have anything more sort of specific then that we can orientate that towards?
Not at all. No, it's very interesting actually, because as I say, you've just hit the nail on the head, really, being so young, and with the prognosis of MEN being what it is. There's this part of me that knows, each time, for example, I go in for a surgery, that may not be the last time that surgery has to happen. And it's kind of always a case of tossing up, when's the right time?
Yeah.
And that's, as you say, you all have these, you guys have these MDTs, and lots of different experts all sitting around the same table. As you said, the one person not being there, is the patient, and that can work, at an advantage and a disadvantage in some ways. I think, how great to be able to be there and contribute. And then I think, well, actually, would I have any idea what they're talking about? Probably not. And it's actually quite helpful for someone to synthesize the information, come to me and say, this is what's going on.
Interestingly, when I was in Oxford, we had MDT, a sort of MDT, with the pituitary surgeon. And then the patient would come up in the morning, have all their various tests and scans and things. And then we'd all sit down with the patient and the pituitary surgeon and say, well, these are the results. What do you think? How bad is your headache? What are we going to do? And that can work, but only if you've got a fairly limited number of doctors, because you don't want somebody saying, oh, I don't think that's a good idea. Oh, that's a bit risky. We do want to do that. And then just in terms of logistics, that will take half an hour, 45 minutes. We'll get through 50 or 60 patients on a Tuesday morning. So that's simply not practicable for this type of disease. And as you say, someone's got to pull it all together and say, this is what we felt generally. These are the possibilities, and then sort of pull it together. It's not easy. If you've got MEN1, I can say at the age of 20, well, let's take out your pancreas, and then the risk of cancer must be near zero. But you'll be diabetic for the rest of your life, taking insulin 2 or 3 times a day. That's not so bad nowadays. We've got insulin pumps and the feedback systems, but nevertheless, it's not something one would actually want to jump into. So, or you can just say, well, I'll risk it. I don't want any major surgery, and you may get away with it. But if I know it sounds quite pedestrian, but every patient is different, and it really has to be personalized. Now, it may be that in the era of personalized medicine, which we've sort of moving into, we'll be able to get markers to say, this pancreatic tumor looks as though it's probably going to be all right, or that one's got rather unpleasant molecular features, probably best to take it out. But at the moment, it's looking at past history, looking at people who've had most experience, and then trying to pull it together into a sort of synthesis. But I think, the outlook is so much better now than it has been in the past, particularly as we're aware, and particularly when patients who are family relatives are undergoing surveillance and diagnosed at an early age. So obviously one doesn't want to jump into an operation with a child, but if that can prevent later complications, yeah, then to go through it. I mean, you've got MEN1.
Yes.
So there's another disease, MEN2. That's not going to affect you at all. But it is known that if you have MEN2 and you have a baby that's affected, in one particular type, that baby has a thyroidectomy within months of birth, and that will prevent cancer in later life. Now, that's a pretty awful thing to do to a neonate, but on the other hand, you know that the treatment will almost certainly prevent cancer, and all they'll end up with is taking thyroid hormone every day. So in that case, we've got a very clear idea. This is what we really recommend. With MEN1, it's a little bit more vague.
I mean, no one's really in an easy position, are they, when it comes to this, because there's so much at stake, and everyone is coming from a different angle.
Yeah.
With different things to be considering. It's certainly, I mean, I often say to people, having a disease, and particularly a rare one, is inherently quite a disempowering situation.
Yeah.
But what I feel within me and what other people are saying as well is that they want to feel like they're bringing the power back into their healthcare, basically, and that's essentially by being looked after by the right people, going to the right places, doing the right things, and I think as you said, approaching things very personally is one of those. In terms of that word empowerment, what is it that patients, is there anything that a patient or patients can bring to the table that makes those difficult decisions any easier at all, or put it this way, that increases that harmony around what really is a team effort when it comes to health?
I think, what's going on there? No, we don't do that. I think information is good. I mean, we're long past the early parts of my career where the patient would say to me, "Oh, it's up to you, doc." Yeah, okay, thank you, goodbye. It was very nice. It made life very easy, but that's not what happens nowadays. And everyone has access to the internet now. That sometimes patients often apologize for scanning through the internet, which I think, and it can be negative if we don't know what's going on at all, and they're sort of scouting around. But when you've got a disorder, then to be knowledgeable about the disorder and to ask reasonable questions, like, I hear in Boston they're doing this treatment. Do you think this is any good? Do you think it's worthwhile? Now, almost invariably for these fairly rare diseases, it is very, very rare for anyone else in the world to have better therapists. There may be administrative problems, there may be waiting times, but I cannot think, particularly for MEN1, that you would get any better treatment outside. But having the knowledge of what's out there and asking the sensible question, I read this in the paper, what do you think of that? Is entirely reasonable. Sometimes we're put on the left foot. Well, fair enough. We need to go away and look into it and check it out. If there's a rare complication and we're not quite sure of, then it's entirely reasonable to say, well, I'm not quite sure about that. I'll go and see what the latest literature is, because that's not directly my area. So an informed, but what's the word I want? A good rapport with the patient and the doctor means that both can be totally honest, and that the patient can ask a question and the doctor can say, I don't know, or I can look it up, or in my experience, X, Y, and Z. And I think that's probably the most useful one. So the patient is not combative, saying, why haven't you thought about this? Why aren't you doing that? I've heard about that other therapy. Why can't I get this? But to open a discussion. And any half-decent doctor will only appreciate that. Say, yeah, okay, let me think about that as a possibility.
I really like that, actually. I think it's, as a patient, it's very interesting because in some ways we are the expert of our own health, because we're
You're inside it.
We're inside it,
Yeah.
I'm in my body, I'm the one
Yeah.
who's dealing with the symptoms and and the repercussions of everything and feeling things as they change. Yet it's amazing, I can go into a consultation, or particularly I used to go into my consultations and feel like a complete idiot, because it was like I just don't really know, I'm not on a level where I can contribute. And I think actually as I've got older, and started to become more honest, and I think more authentic really in what I believe is right for me going forwards, as you said, that kind of personal approach, and sharing that with my consultant, that's only opened doors, because actually I don't really want to be feeling as though someone's fed me a list of options, if there's even if it's long enough to be a list, and then to turn around and think, well, actually I'm being pushed into a corner now and I didn't want this, and that sort of thing. And so I completely agree. I think opening up discussion, and as you say, doing that with honesty as well, can only really lead to a result that's kind of mutually convenient, I guess, with patient and doctor. You touched very briefly upon second opinions and things. I mean, that must be the knee-jerk reaction, really, is if you hear something you don't like or you don't want to hear,
sure,
go and get a second opinion. And then if you don't like the second opinion, maybe even go and get a third one. In terms of your experience, with patients, where's the line between, having the option, having the knowledge, and then actually just becoming overwhelmed and unable to make a decision?
Well, no, I was just thinking that point. Having said that, then there comes a point at which you say, well, I have been in medicine for 30 plus years. I have read most of the papers. I have seen a lot of patients. In your situation, this is what I think is the best option. And sometimes it's when one needs to have that, if asked, that decisive process, because there often are too many options and it's very difficult. And then it's a question of judgment. In this situation, my preferred option would be X. And you may not, you may find this uncomfortable, or we can ask about the other ones. But the difficult situation is when, that there's the old story about the Jewish mother-in-law, and the guy comes along and she said, "Oh, what would you like for supper?" She said, "You can have fish or you can have chicken." And he said, "I'll have the chicken." So what's wrong with the fish? And it's that situation where you say, well, I would go to X. Oh, but what about Y? And you say, well, okay, yeah, Y is a good possibility, but what about X? At a certain point, it does become a judgment call. And you say, I think on balance, this is what I feel would be most suitable. Do you agree? Are you comfortable with this? And unless there are strong objections, or the patient says, I don't want surgery, or I tried this medical therapy and it's horrible, and chemotherapy is just completely out of order, or this may affect my fertility and that's vitally important, then most patients would then at that stage would come to a joint decision. This is what I feel is reasonable, and yeah, okay, let's go with that. But if you then go away and then read something else, that's fine. Okay, come back and we'll talk again. But I think you can be overwhelmed. It can be highly complex. There are a lot of factors, and in the final analysis, our job is in a sense to carry the can. Yeah,
absolutely. Yeah.
But sometimes if you throw too much at the patient, say you decide X, Y, Z, and then the patient says why, and it goes wrong, then there's that feeling, oh, I shouldn't have done that. I'm up with the guilt. And we are experts because we've taken advice. If my car goes wrong, I stand there and I get told what to do. That's fine. It may be too expensive, and I may not want to change all the tires on my car, but I've taken their opinion. For most things, I listen to what they say because they've done it and I haven't.
Absolutely. I mean, I think what I like there is, we are, as patients, we are being supported by our healthcare professionals to go out there and, you know, and find out, to be more informed, to ask the questions and everything. But, you know, also be discerning, because, you know, ultimately, once you know the knowledge, you can't unknow it. And then actually bringing that into a situation where, as you say, there's a decision to be made, but ultimately aiming to come to that decision jointly and as a team, I think is really, really important, and maybe more of a reality now with this kind of, I suppose people are becoming more interested, and, you know, then people feel more proactive, they feel more engaged and enthusiastic, they feel more empowered, you know, it's that word again.
It's not being done to you, it's being done with you, you know. And in the final analysis, we're not treating a disease, we're treating a patient. So, you know, we're two human beings. We doctors, we can get sick too. And it's actually quite interesting when you read accounts of doctors who've become sick, who've then gone to the, as it were, the other side and seen what it's like.
Well, they come back and, you know, they say, oh, actually.
Well, they actually think, oh God, have I been behaving that way all my life? And it's a good learning experience to be on the other side of the bed, as it were.
Absolutely, absolutely. And likewise, you know, I'm quite often talking to different patients, whether, you know, they're MEN1 or whatever, and we find ourselves in these conversations about, you know, what's being said, what's being done, and I sort of have to remind myself, as well as I feel, you know, obliged to remind other people, you know, what must it be like to put myself in, you know, in the doctor's shoes right now, or, you know, it's that ability, I guess, to, as I said before, see, you know, that there are so many different ways of looking at a situation. Ultimately, we all have the same goal in mind, which is to be fit and well and healthy. But, you know, perhaps, you know, different ways of getting there, or different, you know, different things at stake. So yeah, I really like what you fed back there. Definitely.
But it's also, I used to tell medical students, I said, you'll become a consultant, I hope, and you'll earn a good salary. And the reason you'll earn a good salary is to make mistakes. Then obviously they look at you rather stupidly. And I said, well, the point is you accept the responsibility. Every day we make decisions and we take the responsibility for not getting them right. But that's what we do with the best knowledge we have at the time. And sometimes throwing that total responsibility onto the patient, I think it's quite hard, particularly if you've got quite a bad disorder. And, you know, we're in a position to try and make the best decision that we can with the information that we have at that time. You know, things may change and we may get it wrong, and our judgment call may be wrong. And, you know, we all know judgment calls we haven't got right, but, you know, that's our job.
Absolutely. I mean, I think one of the things I've learned is to make a decision and stick by it. And as you say, you know, accept whatever comes with that, knowing that it was done with, you know, it was done backed by knowledge, backed by, you know, trust, all those things we talked about. And you know, it's difficult because, you know, health is so valuable. But I think to look at it like that casts a much, you know, more positive light really over, you know, as I said, what I said before is such an inherently disempowering situation. So
I see that. And I don't know if you want to talk, and there's also the particularly if you then have families, about the feeling of guilt. You know, I've got this abnormal gene and I'm spreading it around and it's just not fair. And the question of insurance and how is that going to affect my family? But, you know, you play the cards you're given in life. You know, there's not very much else you can do. And you know, you deal with it the best way you can.
Absolutely. I'm really glad you said that, actually, because it was one of the things I had written down. Is, you know, it's a lot of it, you mentioned this very, very recently, a lot of it's about mindset, I guess, you know, and you can come into this situation, you know, with the sort of, it's unfair and the, you know, and the woe is me, and you know, what am I going to do, and constantly living, I guess, in that place of fear. And I think fear is a danger on top of the disorder, if that makes sense. You know, it can push you into very strange places. And I guess actually having the mindset of, well, everyone's been dealt their cards in life, and for me it's something with my health. However, the place in which I am to make decisions going forward is incredibly important. So how can I make sure that I'm, as I say, surrounding myself with the right people, connecting, with people who get it, making sure I'm, doing whatever I can on the level of my general health going forward, and reaching out to the people who can help me as well. Yeah.
And also not allowing it to dominate your life, and going to see a doctor too often and having second and third and fourth opinions can dominate what you're doing. It's a fact of life, and one of the reasons, as I said about taking medical advice, is that they're looking after me, they're making the right decisions. I hope. I do trust them most of the time, but in between times I get on with what I'm here for. And I suppose it is a question of trust, that I know that if things aren't right, or if they are going wrong, they will deal with it and pick up the pieces. It's not being childlike. It's just allowing and apportioning responsibility and not taking it all on your own shoulders the whole time. That's quite hard, accepting that other people will sometimes take responsibility for certain things in your life. But your job in life is to enjoy life, or to do life.
I love that. Yeah, you're quite right. I think it's so easy to become bogged down and, in an effort to be engaged, almost to become fixated and then obsessed.
Yeah.
It's a very, very fine line. And
No, completely. Yeah.
Yeah.
To be involved, but not to let it actually be the regulatory feature in your life. And your life is about so many other things. 99% of your life is not having MEN1.
Absolutely. And it's how to shine the focus on on that 99%. And for me anyway, that's been literally to, I suppose, to become, as I say, more engaged and ask questions and facilitate discussions, really, because there's so much, for me, there's so much curiosity in what's going on here, and there's so much that's happened with my health that has led to growth in all sorts of different areas. And as odd as it sounds, it's like how can I turn this very, as I keep saying, very disempowering situation into something much more positive, that I can take from, I can draw positivity from instead, all the while knowing that I've got so much else in life going for me.
Yeah, I see that.
But thank you. Well, I feel like I could talk to you all evening if I didn't have half an eye on the clock. But this has been incredibly fascinating, and thank you very much for your time. And I know that when people watch this back, I think it will give them a lot to think about. And as I say, most of these guys are just a bunch of health enthusiasts who are really curious and want to know more, and be as involved as they can, and I think what you've given here has been very valuable.
Good. Well, thank you very much. I've enjoyed talking to you, Lizzie.